This is CSaP Science and Policy Podcast, where we're bringing you the latest evidence and expertise to improve public policy making. This week, we're proud to present the 8th episode in our series on science, policy, and pandemics, which is brought to you in partnership with Cambridge Infectious Diseases and the Cambridge Immunology Network. In this episode, our host, Dr. Rob Doubleday, is joined by Professor John Crowcroft and epidemiologist Dr. Caroline Trotter for a discussion focused on the new opportunities and challenges for innovative technology in the context of COVID-19.
Welcome, everybody. My name is Rob Doubleday from the Centre for Science and Policy. Today, we're joined by John Crowcroft, who's the Marconi Professor of Communication Systems at Cambridge. And if we've been thinking about interesting job titles, I like one of John's job titles, which is Researcher at Large at the Alan Turing Institute. John, you're very welcome. And Caroline Trotter, welcome back. So Caroline is an infectious diseases epidemiologist at Cambridge, an academic director of the Cambridge Africa program, and Caroline's joined us before, and it's very nice to see you back again, Caroline. The main substance of our discussion today is about digital systems, trustworthy digital systems and digital identities, and particularly relevance of those questions for immunity passporting and other sort of biometric data. But to start with, Caroline, I'd like to turn to you because it would be interesting to hear from your point of view what the current understanding is at a general level of kind of immunity and COVID-19.
Thanks, Rob. So I'll qualify this by saying I'm an epidemiologist, not an immunologist. I think the current knowledge on immunity to this new virus, we're still in the early days. Because it's a new virus, we have no way of knowing if immunity will be short-term or long-term, and the tests still seem rather unreliable. The current advice in the World Health Organization is that we don't have enough knowledge yet to justify a sort of immune passporting type approach. That may change as we gain more and more knowledge, but that's the current situation. I think we're learning as we go along. We don't understand fully about the immune response to this virus, certainly not the duration of immunity, and there's still work to be done on developing reliable tests of immunity.
But John, if we could take a step back and just hear from you about how much confidence should the general public have in the ability of digital systems to store and report on our identity and the kind of very personal data that we're talking about here?
So digital identity is a pretty hot topic right now. We're working on a project with the Gates Foundation across 4 countries in building national digital ID systems that are trustworthy. And let me define trustworthy. That means even if you don't trust the government, that the system will report attributes of associated with an identity somehow to appropriate third parties. So we've been thinking about how that might work if one had a reliable way of demonstrating immunity to something. I'm holding up my yellow fever vaccine certificate, which is a piece of paper which I can show at the border, and I will be required to show this. And we were talking earlier about if you have a pet and you want to travel, you can get a similar thing for a pet that's been vaccinated against rabies, which we kind of care about in some countries where we don't have rabies, which is a pretty horrible disease. So the certificate could be part of that, and it could be an attribute of identity in some system. And the reason you might want it to be digital is that would then allow some kind of cross-border verification. Let me give you a simple example. If you want to rent a car in Italy, if we're allowed to go there ever again, and you come from the UK, you need to produce your driving license. But if you have a recent driving license, you don't have a physical license. You have one at the DVLA's database. So you have to get them to give a token for you to give to the car rental company that allows them to check you have a valid driving license. So that's a one-shot lookup of an attribute. We could do exactly the same if we had a vaccine for COVID-19 that we knew had a very sort of yellow fever vaccine-like level of confidence. You would then easily be able to have a database that held that information. And notice what I said is that with the driving license example, you don't need to have a phone with you. Now, the UK has a few one-shot things like the driving license, but we don't have an ID system per se. Here we have lots of different systems that are not joined up. Some countries, Estonia notably, have a digital ID system for all citizens, and other countries, notably India, have an ID system which includes paper ID, which could also include this kind of attribute in a way.
You said systems could be designed technically to to look after your identity and share information you want shared, even if you don't trust the government. That
right.
And so, could you say something about what that means technically? And to a layper, to me, is then the choice either I trust my government or I trust Microsoft?
No, this is a great question. So this is one of the great breakthroughs in the last few years. We use multi-party secure computations to hold the information. And so that no single party can extract the information. The Estonian system is such a system. They have a very smart decentralized system. In fact, one of the European-wide contact tracing apps for COVID-19 is also a decentralized system, which runs in such a way that no single agency can extract the list of your contacts that you've made while you're infected. They can be notified without anyone knowing who was notified, including yourself. We have systems that, as long as you don't want to do something at super high speed, then they're fine. And of course, if you're just verifying some attribute of somebody that, for example, they have been vaccinated for something, or they do have a valid driving license and so on, then even with a large number of people accessing such a system a day, it's not a huge problem to build this. So in practice, both with, for example, contact tracing apps, but also with decentralized, generalized ID systems, which could contain these things like, proof of immunity or whatever, or good evidence of immunity. Your data is sharded and spliced and distributed across multiple places. So this is, and each one of which can't pull one bit out and extract the meaning, or deny service. In fact, they could be shut down, but you can still reconstruct your system. The Estonian system was designed to be proof against Russia invading them again, and so they've distributed their data over servers in multiple other countries like Switzerland, Sweden, and so on.
Do these distributed systems use blockchain?
Blockchain is definitely not the right technical answer because it's immutable, and as soon as you move stuff off the immutability thing, you're not on a blockchain. So they have a better approach, and their documentation is really good.
I mean, what would you recommend a government like the United Kingdom doing to facilitate the sort of trustworthy digital identities that you're talking about? I mean, does the UK need to have an ID system, a unified ID system? Must it work internationally with others? Does it need to, or can there be ways of developing this that's sort of in line with British kind of attitudes to ID?
Well, so the decentralized type approach would allow you to federate between existing systems. Your passport is another form of ID, your driving license is another form of ID. It might be useful for sharing some information between those at the control of the subject, me, you, us, rather than the government. So that might be a more acceptable way of doing things. Also, with contact tracing, it's completely clear that it's very, very hard to share test data and contact data between countries. So with the example of Ireland, where you have a border that isn't a border, you'd really like the Irish contact tracing app to be able to talk to a Northern Ireland contact tracing app. It will be easier to do that with a decentralized system where you don't have to trust multiple agencies, multiple health services, multiple end users, and multiple app designers. So you essentially disintermediate that trust problem completely. So I think there are multiple examples of why one can take this approach. The UK is sort of weird in the world in that we don't have this as a single ID card. We are very unusual, and we're strongly resistant to the idea. But I think if you start to see how joining the other forms might be useful, that you could gradually have something that emerges which would fit our odds preferences. Social acceptability is not my area. I have lots of colleagues who look at that. The technical side, we can make it trustworthy in a technical sense. What people understand that to mean is a whole different story.
I mean, I think that raises an interesting point about how we communicate this about this technology. I mean, for things to work on an epidemiological scale, like it would be a contact tracing app or an immunity passport, enough people would have to accept it and sign up for it. So I've also been doing some work in infectious disease modelling where we have similar issues with communicating complex ideas. I just wonder if you can expand a bit on the communication side, if not on the acceptability side, which you said is not your area.
Right. In particular, the way we do these decentralized secure systems is pretty hard to get an intuitive understanding. In fact, there are papers from a long time ago by my colleague Ross Anderson, why Johnny can't encrypt and why Johnny still can't encrypt over decades. And that's just the simplest thing of, can you send somebody an email in a way that is secure, that somebody else intercepts the email, can't look at? It's a standard problem. And most of the systems that were devised work technically perfectly, but nobody, even technical people, couldn't figure out how to use them. They were counterintuitive. In fact, public key crypto is famously counterintuitive. When you look at routinely, most people understand when you have a sort of green web page address in your browser, that means it's, you know, it's being secured. And if you ask kids, and when I say kids, I include my kids who are up to 30 years old, they totally get what that means. So it took a generation, you know, for Johnny to understand crypto, or Jane, or whoever. So, but they do now. So it's a thing where you have to have a discussion about things with the public, and then gradually bring understanding. I mean, what we've seen in the last 3 months is an awesome increase in public understanding of the word exponential. You know, just that word. You know, when you look at SIR model, how it shows this curve, and then you say we're going to flatten the curve. What does that mean? We've got this exponential. We want it to go linear. We want it to go sublinear. We want it to, you know, how do you? And people, we're having a horribly hard time. They keep saying there's another burst in this blah blah blah. It wasn't a burst. That if you did a log plot, it was a straight line. But now the public kind of get that idea, which is a big step forward. So in the same way, we could probably do the same thing with these kinds of applications. But we need to have good communicators. Have debates in front of people where they get asked tricky questions. You know, what happens if we usually talk about the participants being, you know, there's Alice and Bob and Eve, but there's A, B, C, D, E, and you want to give examples of what happens if. And there are all kinds of horrible examples. One of the things with contact tracing is domestic abuse. One of my colleagues, Michael Veal from UCL, is a law faculty. He pointed out that you could cause your victim to look like being infected, so they'd be locked down even after everyone else is let out, so you could go on being abusive to them using an app. That kind of thing has to be discussed the hell out of, so that we really understand the downsides and upsides of digital systems and mitigate those kinds of problems. And that's kind of, sorry, that was throwing in a bit of a curveball, but just to show you, we thought, oh, we've got this great approach, and then he came up with this attack, which was, oh wow, we better think very hard about that. That's a really tricky one. We could probably fix it, but then we have to re-explain that to everyone.
So with the NHS contact tracing app, should we be concerned about privacy? And if not, could we add immunity passports to the app?
The NHS app has been misdescribed by its proponents. I'm actually fairly in favour of the NHS app in that it's being deployed and tested, and they finally released the source code, and you know, we kind of know how it works, and it kind of works. And they've also got a DPIA, which is, you know, data protection impact assessment, which needs fixing because it still has the word anonymized and the data is pseudonymized, and the difference matters. And where the difference matters is a rather specific technical problem, but the data is social network data. Effectively, your list of contacts represents your set of people you meet, your family, your kin, your colleagues, your staff and student relationship, all those things, as well as people you commute with and so on. So unfortunately, that represents a graph, and re-identifying nodes in a graph, if you have other data about the world, is terribly easy. So the NHS has to have actually Public Health England have to have a very, very good story about, if they're going to share that data, that they have a audit control over who gets to the data. And epidemiologists, for sure, I think should get at the data, because they can learn more precise models of the SIR parameters, whether there's a relationship between children infecting adults, that's, even though they're much less strong symptoms, maybe they're as infectious or not. You know, I don't think we have a good model, and we could learn that faster and more precisely. But that can be done in an extremely strictly controlled environment with known people doing it, with an audit trail, which is how it's usually done. Not giving the data to Google Health or Microsoft Health, but, you know, under a strictly controlled. And then, by the way, all the data should be deleted, because once you've extracted the model, we have no need for the the set of people that I met in the last 10 days is not statistically of interest, and it's no use. Well, 30 days, let's say. Ross Anderson, I think, and Lillian Edwards actually proposed sort of protection for citizens as a new law, which I think has a 30-day timeout. And I think that combination could be, audit trailing, who gets the data, having a very clear list of the roles of who's allowed to, MRC funded researchers only, not commercial for profit. And then if you want to monetize the model they get out, that would be cool. Cambridge epidemiologists extract a great model and then we sell it to AstraZeneca for a shed load of money, but it's just the model and we deleted all the personal detailed data. I could see that as a story. The NHS NHS, Public Health England, all those folks have to create that very strong feeling of trust in the organisation because of their centralised data. If they use the decentralised system, you can still do some of the epidemiological modelling as I understand it, and then you don't have that worry. You need to have a very good model that doesn't do very few false negatives, but not too many false positives. It's just sort of the ROC for the system has to be good in statistical terms. But it's a great question. I mean, it is the worry, and I think just having an ethical protocol that says these people only are allowed to look at it. The data will be gone after, let's say, 30 days. It might be a bit longer, but some sensible number. And then but what the data is. There are two purposes: contact tracing for the purpose of rapid testing, so you can shorten the time it takes, so the less contacts made by the secondary or third, fourth and fifth contacts, and therefore your R0 comes way down, or it helps it come down because you still have human contact tracing, and so on and so on. And then also epidemiological modelling helps them, but with the strict controls to keep trust. There are other problems though with mission creep, with adding in immunity passports to the same app, which would be a total terrible idea. So it would not be would not create any trial. It would stop people using the app. They go, oh, I left my phone at home. Oh, I left it off. I forgot to charge it last night. All kinds of things would just start to not work. So so it'd be counterproductive. But of course, there are somewhat well-meaning, but slightly technically and socio-technically not people that don't get what that would do, that would say, oh, why don't we just add this in, and this has happened time and again. So we need to resist that somehow.
All these issues were around before COVID-19, questions of security, privacy, trust, and digital systems and digital identities. It just seems that there are opportunities for things to be accelerated and experimented and developed positively. There's also opportunities for things to go wrong. Thank you. Caroline, did you want to come in here?
I just want to comment with 2 points on sort of the epidemiology side. I mean, John obviously is very, very competent in this field as well from his comments so far. But I mean, two things that struck me in the past couple of days, actually listening to lectures from the Isaac Newton Institute. So Graham Medley, who's the chair of SPI-M, was asked what's the goals to inform the models, and what they're really lacking is a good understanding of these dynamic networks, which you could get from this sort of data and this sort of system. So it is important for furthering understanding of disease epidemiology and potential effective control measures. The other was a lecture from Hong Kong, where they've done very well in controlling disease, from Ben Cowling. And one of the main take-home messages from that was, well, they used a whole suite of different approaches. So the more tools you've got, almost the better. We should be considering things as a package, and these new digital tools can be added into other things. I think there'll always be a role for human contact, manual contact tracing, particularly when you're getting down to low numbers of cases. When you're still at high numbers of cases, and the digital apps could be very useful. So I think it's worth thinking about this sort of suite of tools that we've got.
So when you have to act fast and there's less time to think through the integrity of the system, the security, privacy, how do you think we should make trade-offs between these questions, and how should citizens be involved in thinking about what's acceptable? What are the different risk appetites, and what's the role of policymakers in managing that?
So I've given a talk about this 3 times on particularly on contact tracing, because people have totally failed to look at the medical ethics or the technical risks correctly. And having done this for 11 years, and we had to go through a medical ethics committee during a real epidemic, where we had a real app running on real phones with real users. We were rapidly educated, that we weren't not only doing no harm, but our app had to be at least as good as anything else that could be done. That was, if you want to introduce a new drug, if it's not as good as your current drugs in terms of side effects and efficacy, bye-bye drug. So our app, was new, so it let you do contact tracing. Now, what would happen in COVID-19 would be, what does your app do? Well, we actually have evidence from Epidemic. There's a Lancet paper published a week ago based on the Wuhan data that shows that you can reduce the contact tracing from manual contact tracing, which is always done in Epidemic. So there's always manual contact tracing, which takes 3.5 to 4 days on average, down to less than 1 day. So you can precisely compute for some number of people using your app what reduction in R0 that gives. So if you know the infectious disease susceptibility, or in fact, you don't need to know that. You can just say it's a ratio. It'll be this much less. So we can quantify the improvement that the app gives. So that's, first of all, that says if you can reduce the number of people infected, your medical story is good. Right, so you have to come up with with the downside. So what are the things that could go wrong with the app? What bad things could happen in terms of privacy? What other ways could the app be misused in terms of sort of technology for the app? But then you have to do some due diligence and process. I think the NHS has actually done a pretty good job, not as good as the decentralized folks across Europe. In Germany, Austria, Switzerland have done a fantastic job. But the NHS X people published the source code. They published the DPIA. A few weeks ago, there were people saying, "Oh, you guys, we don't trust you at all." There were, technical policy wonks saying, "We can't trust you guys because, what does this actually do? It won't work anyway because you can't work around the Apple, Google, Bluetooth thing." Firstly, yeah, it could work. I knew it was going to work. I know how these things work. In fact, we have been working on stuff that 11 years ago. So technically, it was going to work. That's it. Technical level. How many people would download it? Well, that depends on trust. We're up to 40% now of Isle of Wight. That's up there with the highest country so far, which was Iceland. Iceland, in fact, people didn't need the app. They only had like 10 deaths in the whole place. So, to be honest, it's amazing that 10% of Iceland downloaded the app. But, it was completely irrelevant at that point. But where people think it might be useful, okay, we have a story that medically we're going to improve. We're going to take the number of people you infect because you're in contact with somebody who was infected, and we're going to drop that by, if you had 60% of the population running the app, 60% reduction in the infection rate. That's huge, right? That's a really big number. I mean, we'll get nowhere near that, but let's take 5%, do the numbers on the mortality, that's already easily justifiable. So we have a story about the comparison. Now, what's the privacy story? The privacy story, when you do manual contact, somebody comes in, they test positive in a drive-through test. You lock them down, you isolate them, you sit them down, and you go through their phone book, and you say, "Who did you meet last week? Who were you on the bus with yesterday?" What's the privacy there? A human has a list of all the names this person met. The privacy of the app is better. So actually, in zero time, the NHS X developed an app, based on what we did 11 years ago, but still pretty fast, that has improved over the privacy and the contact rate of the manual system. So in fact, the innovation is good. By the way, John Edmonds, who we worked with 10 years ago, who is an expert in this stuff, he actually pointed out one of the reasons this worked, and we hadn't looked at this for the last 10 years, was this particular coronavirus has exactly the right properties that you can get somebody in early symptoms and have this long period when they could have been infecting people, which you can shut down with earlier contact tracing, which is not true of, for example, HIV, where you have somebody who's infectious but has no symptoms for a long time, which is horribly difficult. You have to do all kinds of other much more complicated interventions. So the innovation here was to realize the app was appropriate and then point out that it's ethically an improvement over manual tracing because it will do no harm and will improve things. At least as far as we can tell, it does no harm. It's hard to see. The Australian app, by the way, does interfere with some Bluetooth medical devices, so it actually does some harm, which is a bit unfortunate. That there are things you have to care about with, and then what is it doing in terms of its privacy? Well, compared to what? Compared to the baseline, which is manual contact tracing, and it's more privacy. It's got better privacy. Not perfect, as we talked about. It's pseudonymous in the data. If you give that data to loads of people, you've totally broken their privacy. But anyway, enough from me for that.
Should we adopt tighter control over activity data because it's also medical?
So in social graph data, the genotype is the strongest example for any social graph. So, that is not a good plan. We should be really super careful about that. That doesn't mean trusted researchers don't do research on it. It just means you don't publish the data. You may need to have publications checked, verified. So, for example, as with drug trials, you have people look at the data, even though it's not published, because it might re-identify patients, but that they can check that the statistics in the paper have been done properly. But there are established ways to do that. So I don't think that's a killer at all. But we should really be careful.
So, Caroline, what do you think about biometric passports, the idea that travel should be contingent on biometric and health data being shown at the port of entry?
I wouldn't like to see that. I think I'm not a lawyer, but the international health regulations exist. So that they would have to be started again. I think it poses difficult problems ethically, financially. But in some cases, you can see it works. So John's already talked about yellow fever and rabies. So that would work if you need to show your yellow fever certificate. That's one disease with an excellent vaccine. You're not showing markers of immunity. You're showing you've been vaccinated. Extending this all the way to showing that you have immunity to something like COVID is I think, difficult technically, but also ethically. And probably you could go so far with this for the known threats, and like we have with yellow fever, but I really don't think it's going to be feasible or very helpful in the context of pandemic control.
So what do we know about acquired immunity and innate immunity with respect to COVID?
Yes, so I'm sure innate immunity will be important. I think we have currently an insufficient understanding of the biology of the virus and its effects on the immune system. People focus on antibody tests because they're easy to do and they're easy to do at scale, which is where it becomes a feasible tool to use. I think the stage we're at now is we don't have a tool that could be used for this sort of thing. I think our understanding will be increasing rapidly. I know there are lots of studies underway, but I think we're not there yet.
Thank you.
John, I mean, in a way, does the fact that there are these? I mean, I think there are so many questions and unknowns about the biology, and yet, I mean, do you feel that there are ways that we can use data that can be collected and from?
Well, yeah. So we're actually working on a version of contact tracing for developing regions as part of our work with the Gates Foundation on ID. And one of the things we're doing is we're trying to get away from the idea of identifying individuals in contact, but rather thinking about risks to people. So what the NHS app actually also factors this in. So for example, Bluetooth on the phone is used as a proxy for a possible contact. But when you report in with the possible symptoms, they actually work out what stage you are, because that can tell how infectious you may be. And therefore, are people within 5 meters may be, susceptible rather than 1 meter or 2. And so you can extend that to groups. So it's about statistical controls to get so how do you do that in a developing region where you have different challenges? Exposes the subtlety of how you design the system even more. Also, the acceptability of what surveillance would look like in different countries shows up with more diversity as well. I mean, you might be okay in Kenya. People are mostly okay with the government there, compared with, I won't go through lists of countries. That would be a bad thing for me to do. But yeah, you know what I mean.
I mean, it's interesting. Thank you very much, both Caroline and John, for joining us, and John for digital systems and the pandemic. I mean, you've been. Maybe I'll ask you a sort of very brief final question, John. How optimistic are you that we are going to be using digital technologies to really live better lives, live happier lives, live healthier lives? And how pessimistic are you that the unintended consequences and the harms are going to outweigh that?
We seem to have maxed out on unintended consequences. There is a bunch of disinformation about that. 5G causes COVID-19 type nonsense, but the amount of it is far less than some other kind of world level incidents where you've seen really crazy anti-vaxxer style madness. So we are getting to grips with misinformation, which is a form of virus, by the way. We model very, very similarly. But how do we know what unintended consequences are? That's like I was mentioning a lot earlier, that my friend Michael Veal pointed out an unintended consequence of the Contact app. If you were to enforce self-isolation, this could be very, very badly abused by certain kinds of people. So it takes some smart thinking. On the other hand, there are people around like that who already think that way. So we may have a skill set, that thinks that way. In the same way, the most awesome thing out there is the medical response. When you look at the people modeling how the virus interacts, gets into a cell and does its reverse transcriptase RNA magic-y stuff, which I don't understand at all. And it's just incredible. And then they say, oh, well, we need treatments and vaccines to do these things with these proteins. You're like, how did they do that in 3 months? When this used to be like 25 years of work, and that's a consequence of digital technology as well, right?
Great. On that note, I'm going to say big thanks to Caroline and John for joining us, and many, many thanks. And next week, we're going to be talking about food insecurity and supply chain resilience.
CSaP Science and Policy Podcast is a production of the Center for Science and Policy at the University of Cambridge. This series, Science, Policy, and Pandemics, has been produced in partnership with Cambridge Infectious Diseases and the Cambridge Immunology Network. This episode was hosted by Dr. Rob Doubleday and produced by me, Kate McNeil. Our guests this week were Professor John Crowcroft and Dr. Caroline Trotter. You can learn more about CSaP's work by visiting us on Twitter at CSciPol or by visiting our website at www.csap.cam.ac.uk. If you have feedback about this episode or questions you'd like us to address in a future week, please email inquiries@csap.cam.ac.uk. Thanks for listening.